Anil Saxena. I request you both to start the proceedings of the mini symposium after you have unmuted yourself. Kindly unmute yourself, please.
Okay.
Over to you, Dr. Sanjay.
Thanks, Sunita. And it's a real privilege to host this particular inaugural mini symposium, actually. And sudden cardiac death, the topic for today. I can't think of a better duo to address this subject matter. And I say that not fictitiously, but because of this very unique expertise that both our faculty members bring on this subject matter. So I just want to spend a few minutes to kind of share with you just what they have accomplished and then why these topics that we have selected for them would be so appropriate for the work that they have done. So let me start off by just briefly talking to you about Dr. Sumeet Chug. He needs no introduction to this audience, but nevertheless, just a few minutes on his journey. So currently, Dr. Chug is the Pauline and Harold Price Professor, as well as the Associate Director of the Schmidt Heart Institute. And he's also the Medical Director of the Heart Rhythm Center, and these are all under the purview of Cedars-Sinai, which is, you all know, a jewel on the West Coast. Dr. Chug completed his medical school in Punjab, Patiala, moved to the US in 1999, and then after finishing up his training here, went on to join the faculty at the Oregon Health Science University. And that is where he actually did this very unique experiment, is what I would say at that time, where he developed a cohort within the population, a community cohort to explore prospectively sudden cardiac death. And this is 1 million plus patients in the Portland, Oregon metro area, where he developed this population of patients who had sudden unexpected death. And it's the SUD study which continues to generate some amazing data that gives us insights into the incidence and the occurrence and the risk factors for sudden cardiac death in the general population. In 2008, he was recruited over to Cedars-Sinai, and then very shortly after joining Cedars, he developed a second cohort there, that is the Ventura County cohort, which is a little bit more diverse population based. And this is sort of the test cohort in which the work that he did in Oregon, he's now finding new insights into sudden cardiac death within the Ventura County cohort. So between these two cohorts of community populations, the insights that we are learning from his work, they're just amazing. And I've had the privilege to hear him speak on this subject matter and also informal discussions. And it's really it's just amazing how much you can learn from him. So it's a privilege to have him, give us a talk on the subject here. But in addition to what he has done, his research, this is 2 decades of completely funded research through some of the most competitive grants. And he's remained funded for the last 2 decades, over $20 million in grant money. And this is just exceptional work. And of course, we've all read his papers. They're some of the highest citations. And this is just not confined to sudden cardiac death. His paper on the world prevalence of atrial fibrillation continues to be cited over and over again. So it's a real honor and privilege to have Sumeet join us. And I really hope to learn a lot this morning from him. Sumeet is kind of, at the pinnacle of what one can do on this. And Rajat, who is my colleague, Dr. Deo, is a rising star, another population scientist. His family is actually from Western UP. Rajat himself was born and raised in the American Midwest. He moved out of there to do his undergraduate training at the MIT. And following that, he has had his subsequent training in some really prestigious institutions. So medical school from the University of Michigan, residency training at Southwestern in Dallas, and then cardiology fellowship training at UCSF and EP training at the Johns Hopkins Institute. So we were very fortunate to recruit him as faculty at Penn in 2008. And since he has joined our group, he has really added this new dimension in terms of population science and exploring risk factors for sudden cardiac death. His work is focused on finding these new cohorts, which are relatively unexplored. And so he started this by really looking at patients with impaired kidney function and the occurrence of sudden cardiac death within that population. And through that, he then generated an international consortium on kidney disease and cardiac arrhythmias. And at the present time, he's continuing to expand that work. He's a PI on a really large NIH study where he's looking at the proteomics of sudden cardiac death within the chronic kidney disease population. He's also ventured into other areas where he's looking at informatics and long-term monitoring methodologies to kind of reveal to us things that we don't quite understand about even populations with atrial fibrillation. He's also building a really unique profile in the genetics of cardiac arrhythmias. He serves as our expert on sudden cardiac death, and that's been recognized well within this region. So he's actually the cardiologist to our professional basketball team, and is also serves as a physician for all the athletics within the larger University of Pennsylvania Institute. So I'm really looking forward to what he has to tell us on the new risk factors for sudden cardiac death and how to monitor these patients. So the two subject matters and two really informed faculty for us to hear from. And so I welcome both Dr. Chug and Dr. Deo, and also everybody else in the audience. Exciting morning to learn about sudden cardiac death. Thank you.
Thank you, Dr. Dikshit. I think that was the most wonderful introduction that I've ever had. I can safely say that. And it's a privilege for me to be here today. Dr. Saxena, Dr. Arora, Dr. Naik, Dr. Narasimhan. There's just so many people on this call that are good friends and colleagues. Greetings to all of you from Los Angeles, and good evening to everyone. So I'm going to start off, it's always really wonderful to share the podium with Dr. Deo. He's a remarkable clinician investigator, and both of us will try to give you, hopefully with a little bit of overlap, but not too much. I'm going to start with the best candidate for the primary prevention ICT. What were we doing yesterday? What should we do today? And possibly, what could we do tomorrow?
Did you, excuse me, if you could go on the slideshow mode, please.
I thought I was in the slideshow mode. Hold on one second. Is that, are you seeing the slideshow mode or not yet?
Not yet. Yeah, now it's fine.
Okay.
Oh, is it? Okay.
Yes, great.
All right. So, so everyone in this audience knows this condition. It affects 350,000 in the US, 5 to 7 million globally, and makes up at least half of all cardiac deaths. So it's a unique condition. Within 10 minutes, anyone who has it is going to die. And increasingly, we recognize that some of our patients present with VT and VF, but otherwise, many also present with non-shockable rhythms. So this is going to be a recurring theme, that what we really want to do is to find our patients whom we can shock. because at this time, really our best bet is the implantable defibrillator. In terms of what we can do for them when the event happens, we all do try. If we look at emergency medicine attempts, really we are trying to make that chain of survival work better. So early access, early CPR, early defibrillation, early advanced care. Now, obviously, this varies throughout the globe as to who has what level of emergency medical services. But even in nations that have very good emergency medical services, the survival rate from cardiac arrest is under 10%. So by the time you call whatever number you call, in the US we call 911, it's too late for 90% of people. So there is a key role for prediction and prevention. If we are going to make a dent in this problem, that's really what we have to do. So let's go through sort of yesterday, today, and tomorrow, and then summarize briefly at the end some of the important points. So as of many years ago, after following the important randomized ICD primary prevention trials, this is really what we rely on. And in this box, I've highlighted the ejection fraction. So it's really about an ejection fraction of 30 to 35% once you have given your patient optimal medical therapy, and there is a reasonable idea that they will survive for at least a year. And this is what all of us are very familiar with. Again, the main predictor of risk in the more common forms of sudden cardiac death. I mean, that's really what I'm going to address. There are rare forms like long QT, Brugada, etc., and we make those decisions a little bit differently. But most commonly, we have either non-ischemic or ischemic cardiomyopathy to deal with. But today, what we are recognizing is that whichever way you look at it, the primary prevention defibrillator is showing us diminishing returns. Many people receive defibrillators that they are not going to be using. Why is that? Well, some of it is we are a victim of our own success. So if you look at this graph on the right, it shows you non-ICD trials, most of them, drug trials between 1995 and 2014, where there was a 44% reduction in rates of sudden death just using some kind of drug, heart failure therapy. In the red line is something that I have taken the liberty of superimposing, and this is not in the intervention or the drug arm, this is the placebo arm. So even in the placebo arm over the years, especially in the drug arm, sudden death from heart failure is reducing, both by how vigilant we are, what the awareness is of heart failure, and how to treat heart failure. So the number of shocks per year and the number needed to treat, so that the number of ICDs we have to treat to save one life is increasing rapidly. So the cost of this, is not sustainable with time, and we have to figure out better ways of dealing with the situation. To add to this, we have data from clinical trials recently that continues to inform us. So knowledge is a moving target. We have the Danish study where no mortality benefit was observed, whether it was the deaths from any cause, cardiovascular death, or sudden cardiac death, in defibrillators in non-ischemic cardiomyopathy. Of course, 60% of patients were also getting CRT, and we recognized in this study that younger patients, especially under the age of 60, may actually be benefiting. But if you look at the interventions from the device, combining shock and ATP, it was under 4% per year. So if you look at the mortality benefit based on age, you end up with a clear idea from at least this study that in non-ischemics, there was no benefit for age over 70 years. There's more data. There's the ICD-2 trial, where basically the message is that if you have patients on dialysis, end-stage renal disease, that defibrillators don't deliver in dialysis. So this was a prospective randomized controlled trial that had to be terminated for futility. And even more recently, there is a paper published just a couple of weeks ago in JACC, a long-term follow-up of SCD-HeFT to 10 to 12 years. And if you notice on the left are the ischemic cardiomyopathy, on the right is non-ischemic cardiomyopathy, and non-ischemics actually don't benefit at all in the long term. So what are we to do? And if we look in different parts of the globe, things are not the same. Every region has its own issues. This is a very good paper from the Asian Heart Failure Registry, where there are different issues that if you look on the left, ICD utilization in eligible patients, there's a lot of disparity based on geography and socioeconomic status. And on the right is a very interesting figure that shows that the out-of-pocket expenditure depends on the GDP. So if you look at India, most of people are paying out of pocket. And if you look at Japan, most people are not. So we have issues to deal with that are based on nations. This is another really nice paper from Dr. Balbir and colleagues, where the ICD, the primary prevention ICD refusal rate is also high in many countries. So there is a need to improve patient awareness. There is a need to improve reimbursement. And, you know, we also need more clinical trials. We can't just live on data from the West. So, for example, the relationship between ischemic and non-ischemic could be different in countries and regions from what we are observing. And this basically shows how for the primary prevention ICD, there are a lot of refusals in many countries. So if you look at this data, it provides you some way of how we could be actually doing a little bit better today. This is the improved sudden cardiac arrest clinical trial that was published in Heart Rhythm this year. And really, if you use a combination of risk factors in addition to just the EF, where you have one or more risk factors, including syncope, non-sustained VT, PVCs greater than 10 per hour, or ejection fraction less than 25%, you see that what they call 1.5 prevention over time does much better in terms of using the ICD compared to 1.0 prevention, which is really just EF less than 35%. The other thing to recognize, and this is data from Canada from a few years ago, is that you really have to think about comorbidities. So if you have a patient who has an ICD, primary or secondary, and there is no heart failure, there are no comorbidities, over time, they will do very well. Their survival will be the best. But when you start adding heart failure, and on top of heart failure, you add comorbidities like end-stage renal disease, or even renal failure, complicated diabetes, COPD, vascular disease, you're going to see that the comorbidities are going to fight against the defibrillator. So today, what we should do with the primary prevention ICD is not just blindly follow the ejection fraction. We must give some consideration to ischemic versus non-ischemic, depending on where we are. We must look at comorbidities, and we must think about age. We think about ageism, etc. But you know, once you cross 70, the benefit of the defibrillator, especially in non-ischemics, or if you have comorbidities, really dwindles. And I like the Canadian guidelines because they actually have a 7-point frailty score. You know, how many of us think about frailty when we implant an ICD? We should be thinking about that. So in addition, depending on where you are, potentially in Asia, that was really important from the improved study, you could think about the 1.5 primary prevention score, not just the 1 primary prevention score. So today, I think we need to move beyond just looking at the ejection fraction. But tomorrow, and that's what I'm going to devote the rest of the next few minutes to, is really how are we going to do a better job for risk prediction for the primary prevention ICD? Well, we can look at this in a couple of different ways. One is for the ejection fraction less than 35%, we must extend beyond the ejection fraction. We must try to combine the ejection fraction with other measures. In fact, there is equipoise for ICD clinical trials in the age over 70. In the US, we have a VA cooperative study, the I-70 trial, which is active and has stopped recruiting though. And we should look for data from there. It's on US East Coast, a really important study. So we can work in the EF less than 35. But the holy grail really is the ejection fraction over 35, where we need to do some different randomized clinical trials that focus on high-risk patients within intermediate risk subgroups. And what do I mean by that? And that brings me to the studies that we are doing, really wonderfully introduced by Dr. Dixit, where we take a population-based approach. The picture on the top shows you Portland, Oregon, in the northwest of the US, and the one on the bottom, Ventura County. Between them, we have about 1.85 million people that we study, because you really cannot study cardiac arrest from 10,000 or even 100,000 people. You won't have numbers enough to do that. And this is a very collaborative study where, my own group of 10 to 15 people, every day we are helped by about 800 people in these two areas. On the right are shown the symbols. We work with almost 30 hospitals, emergency rooms, with 600 paramedic personnel in almost 70 ambulances in the two counties, the police, the fire department, and the medical examiners. So it's really, truly a community-based effort. And we treat the entire community really as a research laboratory. So because the numbers won't be good enough unless we have large numbers in the denominator. So that's what we do. I've talked about these partnerships. And the approach is that most of our subjects, so prospectively, we are waiting for cardiac arrest to happen. It comes through 911 calls most of the time, over 70%. Some come to us from the medical examiner. Very few from hospitals, just from hospital emergency rooms, because we're really looking for out-of-hospital cardiac arrest, which is most likely to have a cardiac etiology. So over the last 19 years or so, between the two communities, we have ascertained over 10,000 presumed sudden cardiac arrests or sudden cardiac deaths. And what we do is to try and reduce the noise in the system, we go back to individual level autopsies and an entire lifetime clinical history and clinical data. And then we try to adjudicate these. And once we have adjudicated them, now we have over 8,000 of them. In a clinical database, we have, over 800 variables. If an ECG was done, maybe 10 of them were done, we have them in digital form. If an echo is done, increasingly we have it in digital format. We look at the epidemiology, and then we have blood samples in a large subgroup of these patients where we can look at the genome, we can look at the various proteins in the blood or the proteome, and we have tissue at autopsy, and we can do some work on those. We compare these cases to controls that are local, and we do, of course, the same things in the controls, and we have over 10,000 of them, except obviously they are all alive, so there's no autopsy data. So just a few brief findings. This is really our earliest finding, that the reason that the ejection fraction is pretty good, it was to start with, but increasingly it is less perfect, because most patients who have a cardiac arrest are not going to have an ejection fraction less than 35%. In fact, only 30% in the Oregon study consistently per year have an EF less than 35% before and unrelated to their cardiac arrest event. At least half of people will have a normal ejection fraction. Maybe a fifth of them will have an EF somewhere between 36 and 55. So this is something that is is kind of important because the same data has been seen in Europe in the Maastricht study. So when we look at our guidelines today, we are missing at least 70% of all sudden cardiac arrests. So we really need some novel prediction tools when the ejection fraction is over 35%. And when it comes to women, the opportunity is even lower. And this is data from Oregon from several years ago. Men are in blue and women are in pink. And if you look at severely reduced ejection fraction on the right, you'll see that men had EF less than 35%, almost 40% of the time, but women only 19% of the time. So we have to work even harder in women if we are going to have equal opportunity for primary prevention of sudden cardiac death. So here's what not just us, but many of us are trying to do. We have to assemble some kind of risk score for sudden arrhythmic death, which goes beyond the ejection fraction. And within sudden arrhythmic death, obviously, we are not really interested in finding out who's going to get pulseless electrical activity or asystole. We want ventricular fibrillation or ventricular tachycardia. That's really what I'm talking about. So what is available to us today, and I'll show you a little bit of our work, are electrical markers done by lots of colleagues, imaging markers, clinical risk. What is ongoing is more genomics and more of the omics that perhaps we can join to the clinical data to get a better idea, and some novel forms of imaging. So that we're not just looking at the vulnerable ejection fraction, we are looking at the vulnerable myocardium, vulnerable interstitium, and there are autonomic and other systems that eventually will also help us. So here is some simple data from the ECG, which is widely available, cheapest tool in our armamentarium. And so this is what we did in the Oregon study. After looking at 9 different parameters, we ended up with 6 that were independently predictive of sudden death. And instead of using each one of them, we used all 6 of them as a risk score on the ECG. Now, this ECG was done before and unrelated to the cardiac arrest. And the ECGs in cases of cardiac arrest were compared to controls, most of whom actually had coronary disease. So we kind of equalized for coronary disease. And here's the data summarized in one slide. If you look on the left, what we are doing is we are comparing a risk score that goes from 0 to 6 based on the number of 1 or 2, 3, 4 ECG abnormalities out of the 6 that somebody may have. And if you compare cases to controls with coronary disease, then you'll see that by the time you get to 4 or more, the odds ratio becomes 20. In fact, if you look at patients with ejection fraction over 35%, the odds of sudden death increase to 26. So this is just an example of how you can take the ECG and clinical factors and ejection fraction and improve the way that you predict risk. And on the right is a validation analysis. The same score in the same manuscript was taken to the ARIC study. And as you can see on the right, the red columns show you how the odds and the risk of having cardiac arrest in the future increase as the risk score goes from 0 to greater than 4. So this is just an example of using the ECG together with the ejection fraction. Here's an example of the echocardiogram. From the same echocardiogram, if you measure ejection fraction, shown in yellow as left ventricular systolic dysfunction, you'll get an odds ratio of 2. If you calculate the mass of the same left ventricle, okay, you're going to get an odds ratio of 2. But if you combine them, it's additive. So suddenly you're at an odds ratio of 4. On the right are very similar data from the Kuopio study in Finland, showing how mass really helps above the ejection fraction. A more recent study from the Oregon data showed we looked at something that we don't look at very often, and that is right ventricular function. And it turns out, as you look on the left, cases of cardiac arrest, these are digital echoes we studied before and unrelated to cardiac arrest, and compared cases to controls. You'll find that the RV FAC, or the fractional area change, a measure of RV systolic function was significantly lower in cases compared to controls. And on the right, you'll notice that when you look at cases, there are in the dark blue, many more of them have a combination of lowered RV systolic function and lowered LV systolic function. So this is sort of a novel predictor that we are kind of evaluating more, but it's intriguing. Here is some work from upstate New York, from Moss, Zariba, and colleagues from MADIT CRT. And as the arrow pointing to the left shows that the eccentric remodeling increases, measured by decreasing, relative wall thickness, the chamber size becomes bigger, the likelihood of shocks in MADIT CRT increased. So geometry could also be important. So the concept really is, and this is where one of the things we want to get to tomorrow, and we are actively working on it, that if you take the same echocardiogram where you measure the ejection fraction, you just add the left ventricular mass, you look at left ventricular geometry, and possibly right ventricular systolic function, could you actually do a better job of assessing risk? And that's really what we hope to get to tomorrow. So in fact, I have shown you a couple of glimpses, but it's really like a rainbow. What we are trying to do right now is we are trying to use AI. We are trying to use machine learning algorithms because this is too much data for us to handle using classical methods of logistic regression, multivariable analysis. So we have this huge pheno mapping project going on in almost 10,000 of these patients. We have a discovery population, we have a validation population, and we're not interested so much in predicting risk of coronary disease, but it's part of the equation. We are looking at comorbidities, we're looking at different clinical, genetic, proteomic factors, and that's what we hope to do in the future for tomorrow for cumulative risk of sudden cardiac arrest. So as a reminder, and just in closing the last couple of slides, I would say that today, the role of the cardiologist and the electrophysiologist, we're actually really all aware of this. It's just a matter of thinking through it. Is we're not just, we shouldn't just be focusing on the defibrillator. Really, I mean, there are 6 conditions listed on the top left, which really we always keep in mind and we work on this. And this is so important. Lifestyle is so important. Medical therapy is so important. In the implantable defibrillator, which is really our main modality, I hope I've showed you that there is room for improvement. We can do a better job of predicting cardiac arrest and who's likely to benefit the most, not just the person who is likely to be at the highest risk. And so in summary, if we think of the best candidate for the primary prevention ICD, yesterday we've just been using the ejection fraction. Today, we are recognizing that over time, there's a smaller benefit and there's a competing risk of mortality from other conditions. There's a question mark against non-ischemic cardiomyopathy. So today we need to balance arrhythmic risk with non-arrhythmic risk. We really should be thinking about frailty. We should be thinking about age, our patient with complex diabetes, patient with renal disease. Are they going to be benefited by the ICD, or is some other condition going to get them before the ICD can help them? This is really important, I think. So we need to make some shared decision making with our patients. Now, in the future for tomorrow, we can't just work with the ejection fraction alone. We have examples like 1.5, which we can use today. The cumulative risk is more likely to be useful. In the ejection fraction less than 35%, I believe there is equipoise for doing ICD clinical trials over age 70 when there are significant comorbidities. For ejection fraction less than 35, greater than 35%, I have showed you some ways of trying to get at an intermediate risk subset where we can start there and try to cull out the higher sudden arrhythmic death risk subset. So tomorrow we will probably have some cumulative risk prediction tools that are more specific for shockable arrhythmic death. So in closing, I'm showing you data that was really put together by stalwarts in the Center for Cardiac Arrest Prevention at Cedars-Sinai, and we are very grateful for funding from NIH and from Cedars-Sinai, and also with a lot of collaborators without whom we cannot really do this work. So why don't I stop there Thank you very much for your attention.
Sumeet, that was terrific. Just a very succinct summary of all your years of work, and it's just so refreshing to get that point of view. And so I would encourage the audience to please send in your questions. We want to spend the next 10 minutes kind of picking on Dr. Chug's brain on the subject, and then whatever questions we can't answer within the next 10 minutes, we'll carry this on to the panel discussion. So I would encourage everybody to please pause. So, while the audience is warming up, I had a question, Sumeet, that perhaps you can address. In the business about, you get the primary prevention ICD using whatever tools we have used. And then after 5 years, 7 years, 8 years, or whatever the battery life may be, there comes the generator change, and over that intervening period, they have not experienced any arrhythmic events on the ICD. And the EFs might have improved a little bit. So if that patient were to show up today, he or she would not meet a primary prevention indication because the EF is not normal, but it's not 35% below. So any thoughts on what we should be doing, and how are you handling that population right now?
So Sanjay, what an important question, and we all agonize over it. I can safely say that everyone on this Zoom screen has thought about this question. So I think we have some retrospective data. So people have done some work. I remember a nice paper from Selçuk Adabal from the University of Minnesota, and there are other papers. Most of those papers would suggest that it is better to put the battery back in, that it is difficult to say that the risk is gone. However, I think that is retrospective data. I'm aware of at least one large clinical trial that has been done at Johns Hopkins. It's a prospective study. It will actually use some objective data prospectively, mostly MRI, because those people are MRI gurus. They like doing MRIs in patients with ICDs. And so a combination of their hypothesis is that if you look at the ejection fraction getting better, patient not having shocks, and less gadolinium enhancement, then probably we should be able to feel better. It's like treating the electrophysiologist, right? Not so much the patient. Feeling better about not replacing the generator. So I think today what I am doing is I'm still replacing the generator in most cases. Occasionally, I have a patient who will come to me and say, listen, doc, I'm in my early 80s now. Why do I have to come back and keep getting this done? Can we just turn this thing off? And honestly, I have done that with some patients where, the likelihood of benefit, but it is really a difficult thing. It has to come from the patient, and you have to kind of both agree. But I think that's the way that I would do it. So I see a lot of questions on the chat. Is it okay if I start answering them?
Yes,
Yes,
feel
I
free
think we
to
can.
do that, or if you'd like us to field them. But yeah, you can definitely go ahead. I can get you started on some if you want. So
Of
very
course,
early
please.
on,
Yeah,
Dr.
please go ahead.
Arya
Please go
had a
ahead.
question about, have you come across physicians refusing ICDs for patients? Your thoughts about that?
Yes, very interesting, because my gut tells me that happens as well, because we all have different feelings, and everything we do in some ways, including politics, is emotional. so I think, but we don't have that data. I would love to have that data, but we don't have that data.
Yep, the US, we generally don't say no because of litigious society, but we look elsewhere for that data.
Yes.
There's a question from Dr. Ullas about his frustration with this whole business of preventing sudden cardiac death by primary ICD, which he thinks is a flawed concept, and I think you alluded to that. So the efforts to maximize benefits of ICD will only yield more numbers needed to treat. I think you've talked about that a little bit. I don't know if you want to address that a little bit more.
No, I understand. I get it that, that given today, I don't think I'd go as far as to call it a flawed concept. I would say that it's really not a strong concept anymore, the way we are looking at it, because the number needed to treat he is right, is going up more and more. So the pressure is really upon us. It's incumbent upon us, number one, to be very careful how we choose those patients, and that's really what I summarized in the talk. And also to really put a lot of pressure in a practical way. I mean, anything we come up with has to be inexpensive, has to be widely available. And so those risk stratifications, I think, are needed before we can continue to use the ICT. So I agree with most of it, not completely.
Can I ask a question, Dr. Sumeet?
Yes.
Yeah, first of all, I must thank you and Dr. Rajat for sparing time to be with us today on behalf of IHRS. Very insightful lecture.
Thank you.
And we have depended far too long on LV ejection fraction alone, as like Ulas pointed out. So it's not really a flawed concept, but maybe incomplete in the sense that we don't know yet how to properly target ICD therapy to a group that really needs it. And that probably is leading to underutilization. And especially when it comes to like competing therapies which reduce mortality like CRT and pharmacotherapy, that has further diminished the returns of ICD therapy.
Yes.
And there has been a concern about that. And most of the meta-analysis published after Danish trial, they all use old data. So I don't think they are valid for comparison. Yes. But there have been two studies recently, which I want your opinion about. One was the Swedish study and one was EU CERT study that is published a couple of months back. So they have shown benefit by ICD. Of course, they were not randomized studies. They used matched controls. So what do you think about that? Swedish study was published last year, and they had a mixed population, ischemic and non-ischemic, a fairly large study, about 3,000 patients.
Yes, I think that if we are going to make decisions about the future, firstly, we need prospective studies.
True.
And some of those studies are using older data from a different context, when possibly we were not as good or as thorough with treating heart failure, among other things. So I think those studies point to the fact that you could still use ICTs, that they're going to primary prevention, you will. I mean, if you look at scud heft in the ischemic population, the benefit goes out to 10 to 12 years. So I don't think we can dismiss the primary prevention ICT. But I agree with you. I think those studies would still give us hope. But I think it's better to have prospective studies because they will help us make better decisions.
Yeah, the key point from your talk is prediction and prevention. So first we have to predict.
Yes.
So besides the LV size and the geometry and the RV function as you talked about, I think scar characteristics are very important. I think Dr. Rajat will probably allude to discuss that in more detail. And the non-homogeneity of the scar as shown by entropy on MRI, etc. So all those factors are very relevant to identify patients in a more targeted manner.
Yes, absolutely. The novel imaging is the way of the future. In fact, if we could get to a really high resolution, because even gadolinium is an indirect measure, you know, it's an indirect way of looking at scar. If there was, for example, if we had some contrast that would bind to collagen, that would be so wonderful, where we could actually see the scar directly. So I agree with you. I think novel imaging is really the way to go.
There is a question from Dr. Yadav about community, AEDs.
Yes.
What is the current status? There was a lot of enthusiasm at some point of time. Are they still very much in use, or in both, like, what is the current situation as far as the external automatic defibrillators is concerned in US?
Yes. So there remains a lot of enthusiasm about the AED everywhere. And I'm going to take the liberty, I've thought about this recently. I have an editorial in JACC in July that I would refer you to, because I wrote it with two of my emergency medicine colleagues, and all three of us put some thought into it. And it deals with bystander CPR and use of the AED. So the AED remains really important. And I think Raj is going to address that, and I'm going to
Yes.
let him. I won't steal his thunder. I think he will give us a much better idea of the AED.
Terrific. So I think in the interest of time and giving adequate discussion points for the panel discussion, if it's okay, Sumeet, we'll move on to...
There are some more questions, so I will note down and sort them out importance-wise, and we can discuss them in the panel discussion subsequently.
Sure.
Thank you very much.
Do you want
Thank you,
to...
Dr. Sumeet. Excellent.
Do you want to take over and to introduce Rajat?
No, please. Yeah, you're the best person to introduce. I will introduce the Indian panelists.
Well, I did spend a few minutes at the beginning of the talk to speak to Rajat's expertise, but as I was saying, Dr. Deo has really become a population scientist with a lot of recognition in this field of identifying sudden cardiac death amongst some novel cohorts, if you would. And his interest was originally in patients with chronic kidney disease, and now he's ventured further into other populations as well. So today he's going to talk to us about the new risk factors for sudden cardiac death and then how to monitor these patients. So Rajat, welcome, and we look forward to hearing from you.
Thank you, Sanjay. Can you all hear me?
Yes, we can.
Yes.
So Dr. Vanitha, Dr. Dixit, Dr. Saxena, ladies and gentlemen, good evening, and thank you for this invitation. This is a real distinct privilege and honor to have the opportunity to speak to this group. Over the years, I honestly have not attended the prior meetings for Indian Heart Rhythm Society, but I've heard much about the organization through some of my US colleagues, including Dr. Dixit. So to have this opportunity to reconnect with some of you and to see you through Zoom is a real privilege, and I can't describe it enough. So thank you. The title of my talk is New Risk Factors for Sudden Cardiac Death and How to Monitor These Patients. So brief overview, I'm going to start by reviewing the epidemiology of sudden cardiac death in India. This is obviously a topic that this group is very familiar with. I will review current work that has generated prediction models for sudden cardiac death, especially in lower risk and intermediate risks populations. And in the final part of the talk, I'll review some novel risk markers and methodologies, as well as monitoring for arrhythmic events. There have been a series of questions in the chat session. Some of those I will address. Others I look forward to addressing more in the Q&A panel at the end. It has been well appreciated for some time that South Asians, Indians in particular, have a high prevalence of coronary heart disease and associated risk factors, such as hypertension, diabetes, dyslipidemia. In addition, large registry studies have demonstrated that ischemic heart disease occurs at an earlier age among Indians compared to individuals from Western countries. To add to this literature, our colleague Dr. Rao and colleagues from Hyderabad completed an important epidemiology study that evaluated the prevalence of sudden cardiac death across South India. Now, given the challenges of conducting a traditional cohort study in a country like India, these investigators used a very unique study design in where they invited medical trainees to complete a detailed questionnaire. And in total, they were able to recruit 478 medical trainees to complete a detailed questionnaire that evaluated and recalled the cause of death among relatives. So of the 478 trainees, these trainees were associated with a total of over 22,000 relatives. And these trainees recalled 1,691 deaths in relatives, in family members, in kindred. Of these 1,691 death events, 173, or nearly 10%, were attributed to a sudden cardiac death event, according to the definition that we would use for clinical studies in the current era. Looking at this in a little bit more detail, of these 173 sudden cardiac death events, far majority were men, 74%, 26% women. Interestingly, 1/3 had a history of myocardial infarction, nearly half had hypertension, 36% diabetes, and 40% were smokers. Interestingly, Dr. Rao and his colleagues also observed that the majority of sudden cardiac death events occurred in individuals between the ages of 50 and 70. And importantly, nearly 50% of the sudden cardiac death events occurred in individuals less than the age of 60, really highlighting the tragic burden of sudden cardiac death in Indian society. Now, they continued with their analysis in this very clever plot where they compared the age distribution that was observed in their sudden cardiac death analysis, as you can see, as evidenced by these vertical red bars, and they compared it to the incidence of acute coronary syndrome seen across India as evidenced by the blue bars. Specifically, as all of you know, India has a very large registry, now over a decade old, the CREATE registry by Dr. Xavier in collaboration with Dr. Yusuf's group in Canada. And the purpose of CREATE, as you know, was to evaluate the characteristics, treatments, and outcomes of acute coronary syndromes in admitted patients across India. There are over 20,000 patients that were enrolled, again, all with an admitted ACS, acute coronary syndrome. And this study included 89 centers from 10 regions and 50 cities in India. And what's remarkable is that the distribution across age between acute coronary syndrome, evidenced by the vertical blue bars, nearly matches the age distribution of sudden cardiac death seen in Dr. Rao's analysis. And the conclusion that these investigators appropriately make is that the existence of a large substrate of undiagnosed coronary artery disease in a younger population contributing to sudden cardiac death is a major public health issue. I think that is a fundamental tenet of sudden cardiac death population-based research that is unique to India and needs to be highlighted in all preventive care and public health measures. And these data contribute to a greater global theme of sudden cardiac death and the general population. We know through Dr. Rao's studies, as well as multiple other studies across the globe, that individuals in the general population have a low relative risk of sudden cardiac death, but as you know, they comprise the majority of cases. In addition, the majority of sudden cardiac arrest patients in the community do not have a preceding history of overt clinical cardiovascular disease. In other words, if you ask these individuals, do you have a cardiovascular disease process? They would say no. Recall, even in the Indian study, only 1/3 had a history of myocardial infarction. So sudden cardiac death is oftentimes the initial manifestation of coronary heart disease. We've seen this theme play out over and over again across US studies, whether it's in women or whether it's in certain minority populations like African Americans. Further, among those with prior cardiovascular disease, most do not have a history of clinical heart failure or a left ventricular ejection fraction of less than 30%. Now, up until recently, there was no historical model to quantify an individual's risk for sudden cardiac death. So several years ago, I collaborated with a series of investigators from across the US, where our goal was to develop and validate a sudden cardiac death prediction model for the general population. We essentially wanted to quantify an individual's risk for sudden cardiac death. So I'm going to explain the study design, but before I do that, I just want to remind everyone that in the US, as you know, the National Institutes of Health, or the NIH, is our largest governmental funding organization for biomedical research. And the NIH sponsors a series, or has sponsored a series of different population-based cohorts. So the most common cohort that, or most popular cohort that I'm sure many of you are familiar with is the Framingham Heart Study, where they enroll individuals from a select geographical region and then follow these individuals prospectively over decades to understand how risk factors associate with cardiovascular disease in general. Other population-based cohort studies have included the ERIC study, or the Atherosclerosis Risk and Community Study, and CHS, or the Cardiovascular Health Study. So these are two cohorts that started in the early 1980s, both population-based. The main primary difference is ERIC enrolled individuals who were middle-aged. Cardiovascular Health Study enrolled individuals who were slightly older. Our goal in this study was to develop a sudden cardiac death model in ERIC and then validate it in a entirely separate cohort, Cardiovascular Health Study, CHS. We took nearly 16,000 individuals from ERIC. We excluded those individuals with prevalent cardiovascular disease and were left with a little bit over 13,000 participants. Again, we wanted to take out the issue of how prevalent clinical cardiovascular disease affects the sudden cardiac death issue. We wanted this to be a pure general population, quote, low risk population. We did something similar with CHS. We took nearly 6,000 participants from CHS, excluded those individuals that had any history of clinical cardiovascular disease, defined as MI, stroke, heart failure, and we're left with a little bit over 4,000 participants. We then harmonized a series of 26 different variables across both cohorts. So you can see the variables that we evaluated: demographic variables, cardiovascular disease risk factors, including alcohol use, BMI, and physical activity. We used a series of different laboratory measures, including potassium, albumin, hemoglobin, cholesterol measures, and glomerular filtration rate. We looked at a variety of electrocardiographic factors, and we also had data on biomarkers, including C-reactive protein, NT-proBNP, and troponin. And we looked at these variables in an agnostic fashion, meaning we tried to eliminate any bias, and we used statistical methodologies to ask, of these different 26 risk factors, which ones are the most important to create an efficient model for sudden cardiac death in our derivation cohort, the ERIC study. Here are the baseline characteristics of ERIC in cardiovascular health study. You can see that mean age is 54 in ERIC, and as I told you, CHS, they were a little bit older, 72. A little bit over half are women, 26% blacks in ERIC, and 15% blacks in CHS. Prevalence of smoking, 26 to 12%, BMI less than 30 in both, blood pressure 120 to 130s, and 10 to 15% prevalence of diabetes. So again, it looks like a reasonably healthy cohort. Mean eGFR is normal and very low prevalence of AFib, normal QT duration in both cohorts, and normal QRS duration. So again, using backward selection, this is our 12 variable prediction model. So of those 26 variables, these were the models that were identified to be the strongest risk factors and to create the most efficient prediction model for sudden cardiac death: age, male sex, black race, smoking, systolic blood pressure, antihypertensive therapy, diabetes, HDL, potassium, serum albumin, low eGFR, and the corrected QT interval. It was actually nice to see that we had a specific risk marker for arrhythmic mortality compared with all the other risk markers that we see, not just in sudden cardiac death, but also other cardiovascular death. And this is the overall prediction equation. Now, I want to point out that there were variables that were not selected in this model. So, for example, left ventricular hypertrophy, or LVH by ECG, QRS duration, heart rate, bundle branch block, these variables were not selected. In addition, none of the candidate biomarkers were selected. We recognize that prior studies have demonstrated that many of these variables are associated independently with sudden cardiac death. However, they do not contribute to the prediction of the outcome beyond the variables already selected in the model. And that's where some statistical model efficiency comes into play. In any case, we use that prediction model to then divide both the derivation cohort, the ERIC study, and the validation cohort, CHS, into deciles of risk. And as you can see here, the overall risk for sudden cardiac death ranges from 0.1% in the lowest quartile among individuals in the ERIC study, and goes all the way up to about 0.05 over the course of 10 years. Similarly, you see here that in an elderly cohort, the highest decile of risk is 11% over a 10-year period of time. So that is about 1% per year. In addition, this model has excellent discrimination. You can see a C statistic of 0.82 in the ERIC study, and in the validation cohort, it's a good C statistic, 0.745, but certainly there's clearly room for improvement here. So the conclusion from this type of analysis, from this study, is that we can develop a prediction model for sudden cardiac death in the general population. We can develop a gradient of risk across deciles in the general population. But again, in low-risk individuals, the very best that we can do with common traditional risk factors, some biomarkers, ECG measures, is to identify individuals that have a risk of about 1% per year, certainly much lower than the threshold for ICD implantation that we currently utilize, at least in the US, in our low EF heart failure patients. Let me just point out, actually, before I move on, this p-value of 0.25 and 0.09, this is a p-value looking at the calibration. So it's asking the question, is there a statistical difference between the risk of sudden cardiac death that is predicted according to the equation as evidenced by the red bar versus the actual risk that's observed prospectively by the blue bar? And the fact that there's no difference, meaning that there's no difference, that there's statistically null, means that that the prediction equation, that our equation actually does fairly well in predicting risk across these deciles, both in the derivation and in the validation cohort. So let's take a step back and let's ask again, let's put this in some greater perspective from the mechanisms and pathways of sudden cardiac death. This is a part of a review article that we created, that we wrote several years ago. But so far, I've shown you that lots of traditional and even some non-traditional risk factors like inflammation or kidney disease, these risk factors are shared risk factors between coronary heart disease and congestive heart failure. And through intermediate processes of CVD and also direct effects on heart, we see cardiac remodeling, like fibrosis, hypertrophy, scar. There's also likely electrophysiologic remodeling. This has been described in various basic scientific papers. There's altered calcium regulation. There's myocardial inflammation. There's altered repolarization. And this is to say that these factors result in the vulnerable substrate. Dr. Chug had alluded to this in his talk as well, that we see these individuals from the population that have this vulnerable substrate. And certainly there is an opportunity to do more imaging, more sophisticated imaging and novel imaging to understand who among lower or intermediate risk populations have this vulnerable substrate, even far before that EF falls to less than 35%, which again is only one part of the substrate. But we all recognize that individuals who have cardiac structural damage, that's not enough for that perfect storm, for that perfect arrhythmic storm. In fact, we believe that there's another central important component, the trigger, the acute trigger. some type of sympathetic activation, ischemia, environmental stress, electrolyte flux, acute hemodynamic stress. There are these alternative triggers that really predispose that vulnerable substrate, that patient with vulnerable substrate, to the perfect storm leading to sudden cardiac death. And more recently, I've really thought about how can we model trigger research? How can we identify what some of these triggers are? And thankfully, in the last 10 years, I would argue that there have been lots of novel methods, not just novel technologies, which in EP we are quick to adopt and we know how to integrate that into our research, into our practice. But there's also been lots of novel methodologies, some of which were alluded to by Dr. Chug, and ones that I want to discuss in a little bit more detail that will help us get to a better understanding of not just what these triggers are, but also can they be identified at an earlier period of time to help prevent patients from dying suddenly. So just as brief review, Dr. Chug showed a very similar slide. Let's talk about the electrocardiogram. We know that ECG measures are associated with adverse cardiovascular outcomes. We know that ECG measures are associated with sudden cardiac death. Dr. Chug highlighted one of his important papers that came out in European Heart Journal a few years ago. This is another paper from Dr. Albert, also at Cedars, that was just published recently in the European Heart Journal. And these are data from the predetermined study, which is a population of patients with coronary heart disease, but mild depressed EF, not advanced systolic dysfunction. And Dr. Chatterjee, Dr. Albert, and colleagues looked at defined ECG abnormalities, contiguous Q waves, LVH, which are anatomic markers, prolonged QRS duration, which is marker of depolarization abnormality, prolonged corrected JT interval or repolarization abnormality, and essentially created a point system such that the higher the points, the more electrocardiographic abnormalities in these known ECG measures, the higher the incremental risk of sudden cardiac death over a 5-year period of time. And what these investigators demonstrated is that when these ECG risk markers as part of a score are added to a clinical risk score and EF, you see even a bigger separation in curves, both in a derivation and validation cohort. So we are familiar in EP as clinicians in our training and our practice, we are familiar and we certainly appreciate the electrocardiogram, probably more than most physicians, and we incorporate that into our practice. And studies like this use well-defined metrics of the electrocardiogram to understand overall risk. But I want to talk now about machine learning and the next phase of ECG analysis. And one type of machine learning is what we call convoluted neural network learning, or deep learning. This is one type of machine learning analysis. And as many of you know, deep learning has been inspired by neuroscience and brain connections. I actually first heard about this in college when I was working with some of the engineers in college. These type of methods involve the use of models or algorithms to and are comprised, of interconnected nodes called neurons. These nodes or neurons interact in this deep learning network and are activated according to the data inputs. And I'll show you an example of this so that it makes a little bit more sense in a second. The activation then propagates through the network and results in an understanding between the relationship of the input and the output. So how does this work? So this is, I'm gonna show you an example of a paper that was published in Nature Medicine from just a couple years ago from the Mayo group, Dr. Friedman's group, which was screening for cardiac contractile dysfunction using an AI-enabled electrocardiogram. So the objective of Dr. Friedman's group in this one paper was to take ECGs and to ask the question, using a deep learning methodology, can ECGs predict, or I'm sorry, can ECGs identify patients who have a low left ventricular ejection fraction, less than 35% by echocardiogram, but without the echo? Just can the ECGs alone identify low EF. As clinical electrophysiologists, we may say, well, let's look for Q waves anteriorly, let's look for a scar pattern, but we know that that doesn't always work, and the overall sensitivity and specificity of that kind of approach is going to be limited. So what these individuals did, and how this deep learning network works, is they took nearly 45,000 patients and their 12 lead ECGs. They took the raw data from those ECG. This is thousands of different digital points across the raw data tracing, across the raw tracing. They entered that data into the algorithm, into the computer, into the DNN, the deep neural network approach. And they also fed the computer which one of these ECGs, which one of these patients was a low prevalence. It's not that common. That's why it survives in the human gene pool. At the same time, genomic research has identified some variants. And 10 years ago, or maybe 12 years ago, I was very excited about studying genomics and polymorphisms in the human code and seeing how they associate with cardiac arrhythmias. But the biology is interesting, but that's likely not going to be the holy grail for identifying clinically the high-risk individuals. Instead, our group for the last several years has been interested in proteomics and protein expression levels, which integrate the effects of genetics and environment. So there's the gene, and we know then that environment, lifestyle, diseases that occur after birth, these all affect protein production. And we also recognize that discovery of candidate biomarkers are limited by our understanding of underlying biology. In cardiology, we have troponin, we have BNP, which have been great finds, but these are likely represent incomplete biomarkers. There's probably much more to the story. Large-scale proteomics, or the evaluation of lots of proteins at one time, can be an agnostic process. We have an ongoing study evaluating proteomics of cardiovascular death, including sudden cardiac death, in 3,500 intermediate risk patients with mild to moderate kidney disease, half have diabetes, and majority have hypertension. And our technology, in collaboration with industry, will assess nearly 5,000 circulating proteins using novel platform that uses synthetically modified nucleotides or aptamers. And we're evaluating whether this enhances prediction of both cardiovascular death and sudden cardiac death prediction. So aptamer-based technology, this methodology, this is considered transformative technology compared to other methods of measuring proteins such as mass spectrometry or immunoassays. And with these aptamers, these are special, again, these are nucleotides or DNA structures, single-stranded, that have been chemically modified. They can identify, they can bind to unique proteins, and through this process, we have over 5,000 aptamers that, again, can identify 5,000 different proteins simultaneously with just a small sample and high precision. So these are some preliminary data, and this work was just accepted for presentation at the AHA later this year. And I'm showing you some volcano plots for cardiovascular death, including sudden cardiac death. And what you see here is we had about 2,300 individuals, again, intermediate risk patients with mild to moderate kidney disease, diabetes, hypertension. They were followed for over 13 years, and there were about nearly 500 cardiovascular death events. And what you can see here is that each one of these dots is a protein. So there are about 5,000 different, or I guess 4,830 proteins. In an unadjusted model, there are 867 proteins that are statistically significant and associated with cardiovascular death. After adjustment for age, sex, and race, this is now 751 proteins. After further adjustment for BMI, blood pressure, hypertension, diabetes, smoking, this falls now to 443 proteins, different proteins that are associated with cardiovascular death. And finally, after adjustment for EGFR and proteinuria, look at this. We have only 12 proteins, 12 novel proteins that are associated with cardiovascular death. These are the names of those proteins with the highest hazard ratios in the fully adjusted model. And these are the proteins with the lowest hazard ratios, or proteins that you would consider to be potentially protective against sudden cardiac death. And what I want to point out, in this type of technology, most of us are not familiar with many of these proteins. These are proteins that have been studied in some science labs, but for the most part, they're relatively novel. Now, I'm not arguing that we go out and we start measuring these in the clinic, because if you look at the overall hazard ratios, they're quite modest. But we're hoping for two things. Number one, this will teach us biology. This afternoon, actually, my group is doing its first pathway analysis, where we're going to take all these proteins and we're going to say, what are the different biologic pathways between the baseline measurement when the blood was actually collected and 10 years later when the cardiovascular death occurred? What are the different potential pathways that could be resulting in disease and eventual demise? The second thing is, we're going to combine these proteins to develop various risk models and see, can a protein-only risk model actually outperform a clinical risk model? Or can it enhance a clinical risk model? And the final thing that we're doing, and we've applied now for further funding as the second phase of this, and we'll find out next month if we get funded or not, will be to say, we have blood at collection time point 1, and then we have blood at collection time point 2, and do a change in these markers over time, enhance or mitigate the risk of cardiovascular death, and in particular, arrhythmic mortality. So these are ongoing studies, and this will be a virtual presentation in a few months, and I hope you can join. So we can. We're obviously going to be hard at work between now and then to clean up these data and to show you more results in November. So Dr. Vinita, Dr. Dixit, Dr. Saxena, ladies and gentlemen, in summary, public health interventions, including education, screening, risk factor modification, and CPR training, have the potential to reduce the burden of sudden cardiac death in India and are important. Novel methods and analytics will continue to evolve and should be evaluated by all in appropriate settings. And finally, I cannot emphasize enough, collaboration is key. I'm an electrophysiologist. I work with some very talented electrophysiologists on the clinical side, but I'm also fortunate to be at an institution where there are incredible engineers, incredible biostatisticians, and then I have incredible colleagues like Dr. Chug, who I interact with every few months, and where we have lots of ongoing studies. And I hope this is genuine. I would welcome collaboration with any of you. I obviously have an incredible alignment with India for my family, visiting India on multiple occasions, and would really appreciate the opportunity to work with any of you in the future. Thank you.
Raj, that was terrific. I hope everybody appreciates the enthusiasm and the passion that Raj has for this subject. And I can tell you that there is never a conference that Raj is in during our morning meetings where he has not made us think about a subject matter in some other terms that we would never have conceptualized it. And that's thanks to, this insight and research that he has. So this was terrific, Raj. Thank you for that. There have been a few questions that have come through. I think the audience are still digesting the knowledge that you shared. One of the first questions that came, Raj, was on the ECG parameters that you showed us. And the question was about the fragmented QRS. And was that not included in your model? And what does it represent? Is it repolarization abnormalities? Is it scar? Is there a way to differentiate that? And more importantly, what does it mean actually when you see fragmentation?
Yeah, no, thank you for that question. I think Clinically, we believe that a fractionated QRS complex means something. Clinically, we've all seen cases, especially in our group, we see lots of cases with fractionations over the RV. For fractionation in the right-sided leads, V1, V2, in the septum, we think are portend a grave prognosis. And we oftentimes see then the correlations with electrocardiograph, I'm sorry, with anatomic disease. In fact, can I share my screen just very briefly? Sorry. Sorry, let me just show you here. So a few years ago, one of our fellows and I, Dr. Pathak, who's in Australia, we wrote this review article, and you know, what you're talking about is fractionation. Now, this is intracardiac fractionation, but you can even see fractionation on the electrocardiogram right here, right? Leads 2, leads 3, even in lead V1. And certainly we see that fractionation on a surface electrocardiogram correlates to areas of abnormal myocardial potential, or SCAR. This was a case of ARVC, and certainly, yes, it does mean something. The challenge really is, can we effectively evaluate fractionation in large cohorts? Is it ready for prime time? Are we ready to say, let's take a large population and screen people for sudden cardiac death just by looking at fractionation? And I think the challenge that I have with that is that there's not a consistent way of doing that. We know that fractionation, for example, or this concept of earlier polarization patterns can be benign, commonly seen in the inferior leads. Everyone has a little bit of a different definition, or how do we measure it? So there's been work done to refine it, to make it more consistent. But I think that's something that will continue to evolve. But I think at the same time, these machine learning methods, where we're just looking at the raw tracing in general, will probably identify correlates of that pan out to be important for risk prediction.
Thank you. There's another question, Raj, on biobank, whether that's helpful, and if so, what are the challenges in maintaining this, especially when you have blood samples and you're trying to do a temporal analysis and collection. So just your thoughts and your experience.
No, this is excellent. I really appreciate that question. I've had a lot of, I have a lot of experience with the biobank. I've been working in this at University of Pennsylvania for the last 10 plus years. And we are clinicians first. We are electrophysiologists. We understand the heart. And what I would say is it's actually very simple and straightforward to collect blood. I think that you need a lab, you need a freezer that's minus 80 degrees, you need a station to spin down the blood, and you need to teach somebody how to do it. It's not that challenging to collect and store blood. What I find to be the challenge is the phenotyping. How do you maintain a comprehensive database on lots of characteristics for patients where you have blood samples? We have, our group does a very good job of collecting data from AFib ablation and VT ablation. But we have a meeting probably once a month to figure out how that can be improved. How can that be enhanced? Now, I would argue we want that same type of comprehensive data set, that same set of phenotypic, deep phenotyping in our patients to go along with the biobank collection efforts. So yeah, I mean, if you have specific questions about biobanking, I can send you our protocol. I'm happy to send that to you, share it to you. I'm sure you can ask Dr. Chug as well. He could share it with you. But it's, I think that's actually pretty straightforward, especially when patients are already in the hospital or in the clinic and somebody's drawing their blood anyways. So.
There is another question, Raj, on the most common cause of sudden cardiac death in the chronic renal disease population. Is that something that you've been able to tease out?
Yeah, thank you for that. That's very good. I like that question a lot. When I was a fellow, I predicted it was all VF, and I was wrong. I wrote many grants to industry. I wanted them to do the sub-Q ICD study in dialysis. Anyways, thankfully they didn't do it. Let me talk a little bit about chronic kidney disease because as Dr. Dixit had indicated earlier, I've spent a lot of my time thinking about kidney disease. Remember, estimated glomerular filtration rate. Once it's less than 60, that's CKD state, that's chronic kidney disease stage 3. That's mild kidney impairment. Then there's moderate kidney disease, say between 40 to 50 milliliters per minute per 1.73 meters squared body surface area. Once you go down less than 15 to 20 milliliters per minute, now we're talking about more advanced CKD stage 5 or onto dialysis. I would argue that non-dialysis dependent CKD is a different phenotype than dialysis dependent CKD. In dialysis dependent CKD, we now have several studies, the LINK studies, where dialysis patients were had a LINK device implanted. And we know those aren't ventricular arrhythmias. We know that those patients, they have occasional VF or polymorphic VT, but predominantly it's bradyarrhythmias or it's PEA that leads to sudden death. And that probably explains in part the data from ICD-2 that Dr. Chug showed you, where there's no mortality benefit with an ICD in dialysis. That if a dialysis patient is dying suddenly, it's due to PEA or bradycardic event, most likely, not due to a VF or polymorphic VT, not due to a shockable rhythm, due to a non-shockable rhythm. So that's in the advanced CKD. I will say, I would be very cautious toward extrapolating these dialysis data to the mild moderate CKD population. I still think that's a different beast. I think that is a very different physiology. I think we have to be very careful. We know that population has a high burden of AFib. We debate clinically how to anticoagulate those individuals for various reasons. But in general, they should be anticoagulated. And I think this story on sudden cardiac death is real. We need more studies on characterizing their rhythm.
It's great, Raj. So I think it's getting a little late in India, and I want to stay on time. And thank you so much for that really comprehensive talk. And I'm going to hand it over now to Anil to kind of take us through the rest of this session, which is the panel discussion. That's going to be just as exciting, I'm sure.
Thank you, Sanjay. It has been really nice to have you here. And of course, I must, again, on behalf of IHRS, thank Dr. Sumeet and Dr. Rajat, both of them, for sharing their time and really insightful lectures, I must say, and wonderful discussion. So going on to the next part of, last part of our program today, we have a panel discussion, and just to continue our focus on the prediction and prevention, we have a very distinguished panelists. I must introduce them. Dr. Narasimhan, who need no introduction to this group. He's an eminent electrophysiologist of the country, and currently he's Director of Electrophysiology at AIG Hospital, Hyderabad. Dr. Narasimhan has done a lot of work on identification of and mapping of the substrate, myocardial substrate, which causes malignant arrhythmias. And as we have been hearing in the evening from Dr. Chug and Dr. Rajat, that understanding that substrate or the nature of that substrate is very crucial in identifying the patients who are at high risk. In fact, we are looking at finding high vulnerability in the low risk group, which are like general population or patients with cardiac disease and preserved LV function. And we look for low vulnerability in patients who conventionally are thought to be at high risk, say low ejection fraction, so that we can target the ICD therapy better. And I'm sure Dr. Narasimhan can throw a very good light on these aspects as to how to identify within the context of India, how to identify the high-risk group among the patients with somewhat preserved LV function, and finding low-risk individuals among the patients with poor ejection fraction. And the other panelist is Dr. Ajit Kumar. He is a very, very senior and respected figure in India. He is head of cardiology at Shri Chitra, and he has developed a wonderful program ably assisted by Dr. Nambudiri, one of the finest electrophysiology programs in the country. And besides that, he's part of several government committees and groups which look at various public health problems. So he's uniquely positioned to tell us about various obstacles that exist and the opportunities that exist in tackling the problem of sudden death in India, because it's not easy. Being in a developing country, we have very poor public health infrastructure and the response system. So how to utilize that maximum for the benefit of containing sudden death, I think we'll get very good insights from him. So, but first let me turn to Dr. Narasimhan. Dr. Narasimhan, tell us, what do you think about assessing the risk of sudden death in patients who have relatively preserved LV function? Because a lot of sudden deaths happen in this group, and the current guidelines many times don't recommend ICD. On the other hand, a lot of patients with poor ejection fraction, ICDs remain unutilized. So how can we resolve this paradox?
Very much, Anil. And at the outset, I would like to thank both Sumeet and Rajat for the wonderful talk on sudden death. In fact, we learned a lot on this. Now, basically, as a clinician, you look at causation. What are the causes of causes? We look at cytokines, ECG, and other things. Simple example, if you have a person who has lost a father or loved ones, within the next couple of months, the incidence of sudden cardiac death increases. If you look at the environmental pollution, shutdown happens, the sudden cardiac death risk comes down. So these are, as physicians, we are used to measuring things which we can measure, which is, say, blood sugar, cholesterol, so on and so forth. But I think in a developing country, especially with so much of societal pressures, one thing which we are not able to quantify is the impact of environmental pollution, psychological stress, for example, hostility, uncertainty of future, economic doom. These things have all been correlated with increase in incidence of overall mortality. Very strong prediction in terms of increase in mortality. I have a feeling to both these wonderful investigators, if there is some way that you can kind of look at these proteomics in those patients which had identified the markers of sudden cardiac death, whether they will correlate with psychological stress and environmental pollution, because these are things which are emerging, and they are not, the impact is huge in terms of societal implications on this. You take even, for example, in Africa, where the tribal population versus urban population, the risk of sudden cardiac death is very high, where in one, whereas it's much less in the other. So I think that will be my take on this. This is a low-hanging fruit for a country like India to understand that, for example, these are simple things which we forget in day-to-day practice.
Great, thanks. So let me ask Dr. Ajit now. Dr. Ajit, you have been part of several initiatives and the government committees also about various public health issues. Is sudden death discussed there, and what are the obstacles and challenges you think there exist in the public health care delivery system which need to be addressed, and how can we address them?
Thank you, Anil, and thank you IHRS for giving me an opportunity, and wonderful lectures by Dr. Chug and Dr. Rajat. Before I take this specific aspect, I would like to make my one comment upon specifically, since all of you have driven to the point that we need a scoring rather than a one particular variable when you want to decide the need for an ICD. I think one of the problem of making this single entry cutoff value of ejection fraction has been the problem. See, when you take a single entry cutoff for a continuous variable like ejection fraction, you can be rest assured that the mean value of this particular value would be much around 25% or so, and that is what drives the results. But then you end up putting 35% as the value for which you need to give an ICD. So essentially, putting a binary cutoff is the basic fundamental problem in all these trial designs. And it is quite natural that you need to add other factors into it and score it up, much like a Euro score, which obviously will contribute to make the decision. So I think the particular, for example, if you take Maddie trial, the value was 35%, but what drove the result was of ejection fraction around 25%. So I think the problem here is that you need to have a better score. Now, whether you depend upon the scores that Dr. Chug said or whether you would depend upon artificial intelligence measures, what Rajat said is a different matter altogether. That's one. Now, the second aspect which Dr. Anil asked regarding what is the government priorities regarding sudden cardiac death and how you tackle it. I really don't think in the Indian context there has been a discussion at all on this aspect. Primarily for, I think the government is more concerned with health delivery and preventive measures in much different levels. You see, you can, if you look at the number of ICD implants across the geographies, I think US puts around 250 or 500 per million. The average number that should be is around 100 per million. UK puts around 50 per million, and India and China puts around about 3 and 5 per million. And I probably think the problem why the government does not address these issues because it's not a priority in terms of economics. And as long as and of course with all these current problems with infective illness like COVID and all, I'm sure the money is scarce to put it up. So we have not really had a discussion at all on these aspects. But I think in the context of what the government is looking at, for example, even the state from where I come from and from the government of India, it is actually looking at all these other non-infective diseases at a much specific level, and I've put in committees to look at it, but that's at the end of it.
Thank you. I think both points are very important because this 35% cutoff is basically artificial threshold that we set at some point of time to a continuous variable. And the ROC is not very great, but what Dr. Rajat showed, like a multi-parameter, intelligence-based models, the ROC was 93%, so a lot of 93% area under the curve. That's very, very predictive. So I think that is the future because this single parameter LV ejection fraction is certainly not good enough. I wish Dr. Yash was there because we wanted him to be involved in this discussion. He is very passionate about primary prevention, this thing, of course, against it, but, and he has created a very good system, a very good institution, which has very committed team of trainers who train people in CPR, general population, healthcare workers, and they have a program called iCare. But he was, for some reason, not available. I would have loved if he is here. He can unmute himself and say a few words about that program because that's amazing. And he's very keen to involve everyone in that program. The team can come and train people in different regions of the country and help in setting up such programs, which really helps a lot of people. And they've saved a lot of lives in Mumbai region. Dr. Yash, if you're there, if you're not there, then I can ask maybe one last question from Dr. Chug and Dr. Rajat. There's one question which Dr. Padmanabhan has asked, and that is that when we compare ischemic versus non-ischemic, ischemic seems to be more homogeneous population, except of course some patients having worse scar characteristics. But the non-ischemic, is there like we take a very diverse group of entities in one group and that leads to some dilution of risk when we compare the ICD therapy in ischemic versus non-ischemic, and segregating those diverse conditions might identify as to which are the disease entities which have a higher risk. Is that possible?
Why don't I start out
Yeah, please.
with that really important question? Yes, so really what Dr. Saxena, you're asking is, I mean, is there a high-risk subgroup within the non-ischemics that we could find? And I think absolutely. Every time we do the point that Dr. Ajit made, that, you know, you have a cutoff or you have a categorical way of cutting it off, a variable, you are not going to be looking for subgroups that are at higher risk. So certainly, whether it is based on the type of genetic mutation that leads to non-ischemic cardiomyopathy in some subgroups or other features, that is certainly something that would be very important. The only thing we have right now is age, and so we need to get better than age.
Thank you. Any other question from anybody else?
Anil, I have one
please.
question to Dr. Rajat. See, this machine learning or neural networks, which you say or people claim, is basically, in the end, it's all a matter of pattern recognition, isn't it? I mean, I'm sure if one of the patterns would have been the person who's reporting it wears a blue shirt, that also the machine takes into account, because the machine does not look into the logic of what actually decides the problem. It only takes the entire data into account and then makes out an algorithm and then comes out. So I think the neural networks, in the end, I think probably the human element is also as perhaps important in making a decision, because you are going logically and the machine is going, I wouldn't call it illogically, but machine is going on pattern recognition. Is that correct?
Yeah, I think both are important, right? I think that in the traditional machine learning, the deep neural network, sort of the example that I showed, that works best, for example, when you have Google Picture, or when you download your pictures, the computer can recognize if this is you or your family member. It gives you the exact name. The radiologists, for example, have done a tremendous job with this, or histopath, like in cancer diagnosis, they've done a great job with this, where the computer can see the image, and because it's trained itself to looking at so many different examples of what's disease, what's non-disease, it's been able to pick up the subtleties, right? So it has its own sort of logic. It's all empiricism, and it works. It's been successful. But I think that for us, part of it is we're not just trying to make a diagnosis to then give, for example, chemotherapy, right? We don't have 100 different options for sudden cardiac death prevention. That's part of the issue. I would say that once we identify that higher risk group, I think what becomes important is to say, well, what is it about their characteristics? What is it about their phenotype that makes them high risk? That will then lead to drug development. That will lead to other interventions. That will make us better clinicians, so that when we see these individuals in clinic, we can say, yes, you're at higher risk. You really need to keep track of your blood pressure, your exercise, your diet. And then hopefully, as I said, other interventions.
A good point. And about one thing about deep learning is that it's a continuous process. It's a continuous evolutionary process. It keeps getting better and better. So I'm sure it'll get better in future as we have more and more experience and data.
Yes,
one of the things which has been asked is, please.
So just a comment to echo Raj, that, you know, even with machine learning, it's a whole huge field. So you can have supervised learning, you can have unsupervised learning, you can use traditional methods together with machine learning. So that's sort of the approach that we are trying to use, is to use traditional methods and compare them to machine learning methods. Because yes, it can be garbage in, garbage out, but there are ways of doing traditional methods, unsupervised and supervised machine learning, because one big advantage is that when you have terabytes of data, then the old machine learning or the logistic regression sometimes fails. So you can have the advantage of using larger amounts of data, But absolutely, you have to be very careful and have to check what the answer is, not use it blindly.
True. One of the
So I was going to
questions.
say that, we tend to not understand this aspect quite as well. But for some of our colleagues who live in the Palo Alto area, into Turkey and some other, you talk to them and their way of looking at it is completely different. And as a cautionary thing, just reading Yuval Noah Harari's Homo Deus, I don't know if you've had a chance to look at it, but for those who are uninitiated, I highly recommend reading that book because I think it will make you realize just what our roles are and how quickly they are diminishing when it comes to these other abilities. But along the lines of using technology to better understand patients, I know both Raj and Sumeet have looked at long-term monitoring. I know Raj's interest in this area continues to evolve. And to the question that was raised about the accuracy of data and how to really tease that out, one of the challenges has been that you get all this information from, let's say, implantable loop recorders. And I feel like only half the time can I trust what's coming back to me in terms of arrhythmias, in terms of their diagnostic abilities. And so, while it's an easy platform to implant and it can give you a lot of information, just what is the utility of that? The whole business about what you're getting out of it and how you're interpreting it and sensory overload and managing that data. And of course, for us in the US, the liability of having that data sitting there, which goes undiagnosed for an extended period. And lo and behold, if somebody has something bad happen. So I'd like to hear the panel's take on it.
Well, I'll just start off very briefly. It's an excellent point, Sanjay. I mean, I totally agree with you. I think that at this point in time, I think the way that most wearable devices are, whether it's Link or whether it's 2 to 4 week, I think the utility of those devices are around a very specific clinical question. And that's how I think of it clinically. Is there AFib or no AFib? What are the palpitations due to? Was the VT ablation successful or not? But I think that those devices provide an opportunity to learn much more about the electrophysiologic state. One of the issues is that there have to be better collaborations and partnerships with industry on this. Because in order to understand the intricacies of the data, you want more than just 20 pages of report. You actually want all the raw data. And it's actually, to be honest, it's actually a big deal. There's a lot, it's very challenging to get the raw data, for example, from Link, to ask Medtronic, give me all the raw data on my patient's Link device. There's a lot of legal battles about who owns that data. Is it the patient's data? Is it the health system's data? Is it the insurance company's data? Is it Medtronic's data? And I'm using Medtronic as one example. You could be any company. But I just think that you need that type of data to really understand the extent of what's possible from continuous rhythm monitoring, in my opinion.
Yes, and I agree with Raj. I also think that this is where AI can help you, because there's a lot of work going on in this space. So we have information overload. And as a simple EP doc, how can I look at each one of those tracings? So if there was a reliable way for a machine learning tool to go through and say, this patient had, 46 episodes of AFib, and for this much time, that will really be very helpful to us. And I think that is once the technology tiger is out of the box, you have to run away, and not let it get you. So you have to. So AI, I think, is going to help us there. There will be some time periods where we will be uncertain about it, but I think it's going to make our life eventually make it simpler.
Dr. Narasimhan, one last word from you.
No, this is really exciting. I've learned more from attending to these listening to these giants in this area, and really enjoyed both the talks.
Thank you. I think we are reaching the end of our discussion. I must thank both the wonderful speakers, Dr. Chug, Dr. Rajat, and of course Sanjay, my dear old friend, for organizing this and helping us with this program. Thank you so much, Sanjay.
Thank you.
No,
Thank
All
you
of
very
you.
much.
it's a real pleasure. Once again, Sumeet, Rajat, thank you so much for sparing the time to join us. I'm sure the audience learned as much as I did. And, I see Rajat every day. I see Sumeet so often. And yet today was an enlightening conversation, just like
Absolutely.
Wonderful.
We must thank our tireless Dr. Vanita for always being there.
Thank you for trumping me on that. I was just going to say that. So let me echo what Anil said. But I also want to thank the audience. This is late in India. And
Thank
for
you.
everybody who joined us and stayed for this entire discussion. I hope you benefited from it. And
Absolutely. Thank you
take
so
time.
much.
Great. It was great.
Thank you,
Actually, we
Dr.
had a
Sumeet,
very
Dr.
good
Rajat, once
audience.
again. Thank you.
Despite
Thank
being
you
so late, we had a very good audience today, and I'm sure everybody enjoyed a lot. There were so many questions. I think I will send the questions to you, Dr. Sanjay, and maybe you can ask the speakers and all, like you did for your own symposium, to answer them and mail them back. So it will be great.
And
Yeah,
we will
that would be
continue to
great.
request you for your time in future. Both of you.
Anytime. It's
Thank
a
you so much.
privilege to participate.
Thank you so much.
Thank you
Thank
so
you,
much.
everybody. Signing off. Bye-bye.
Bye-bye.
Take care.
Sumeet, just while we have you for a brief second, so what we'll do is, what Vanita will do is she'll send out these questions in an email,
Yes.
and I'll just forward it to both you and Raj, and
Yes.
you can respond with the red letter, and Raj can respond with the green letter, so we can identify the two responders.
Done. That would
Yeah.
that would be wonderful. Love to do it. Thank you.
Thank you so much, everybody.
Thanks. Bye-bye.
Good night.
Thank you
Take
so